Welcome back to the Charcos Academy learning series on nursing management of substance use disorders. This is Module 5, Nursing Interventions and Rehabilitation. In the previous modules, we explored the foundations of substance use disorder, learned to recognize clinical presentations, mastered assessment tools, and examined treatment modalities and pharmacotherapy. Now, in Module 5, we focus on you, the nurse, and your essential role in substance use disorder care. We will explore nursing diagnosis, care planning, therapeutic communication techniques, acute care interventions, discharge planning, and critically important, self-care for nurses. This module is about translating everything you've learned into practical, compassionate, evidence-based nursing care. By the end of this module, you will be equipped with the skills and confidence to provide exceptional care to patients with substance use disorders. By the end of this module, you will be able to 1. Formulate nursing diagnoses for patients with substance use disorders. 2. Develop individualized care plans based on patient needs and treatment phase. 3. Apply therapeutic communication techniques that build trust and support recovery. 4. Implement acute care interventions for intoxication, withdrawal, and medical complications. 5. Coordinate discharge planning and community resource referrals. 6. Educate patients and families about recovery and relapse prevention. 7. Practice self-care strategies to prevent burnout and compassion fatigue. 8. Address stigma in healthcare settings and advocate for patients. These are the core nursing competencies that make a difference in the lives of patients with substance use disorders. The nursing process is your roadmap for delivering systematic, patient-centered care. Let me walk you through how it applies to substance use disorder care. Step 1. Assessment. We covered this extensively in Module 3. Gather comprehensive data: health history, substance use history, screening tool results, physical examination, vital signs, laboratory results, psychosocial factors, and support systems. Step 2. Diagnosis. Identify nursing diagnoses based on assessment data. Nursing diagnoses are clinical judgments about actual or potential health problems that nurses are licensed to treat independently. We will explore common nursing diagnoses shortly. Step 3. Planning. Develop individualized care plans with measurable goals and expected outcomes. Prioritize diagnoses based on urgency. Safety issues come first. Involve the patient in goal setting whenever possible. Step 4. Implementation. Carry out interventions. Direct care, medication administration, wound care, monitoring, education, teaching about medications, coping skills, resources, coordination, arranging referrals, collaborating with the team, advocacy, ensuring patient rights, and fighting stigma. Step 5. Evaluation. Assess whether goals were met. If not, why? Do we need to revise the care plan? This is an ongoing cyclical process. You continuously reassess and adjust. Your nursing process is dynamic, not static. Substance use disorder care requires flexibility and responsiveness. Let's discuss the most common nursing diagnoses for patients with substance use disorders during intoxication or withdrawal. 1. Risk for injury related to altered mental status, seizures, or impaired coordination. Rationale: patients experiencing intoxication or withdrawal are at high risk for falls, aspiration, or self-harm. 2. Ineffective breathing pattern related to respiratory depression from opioids, alcohol, or sedatives. Rationale: respiratory depression can be life-threatening and requires immediate intervention. 3. Risk for fluid volume deficit related to vomiting, diarrhea, or decreased oral intake. Rationale: common in alcohol withdrawal, opioid withdrawal, and stimulant use. 4. Acute confusion related to intoxication, withdrawal, or metabolic disturbances. Rationale: altered mental status can indicate delirium tremens, Wernicke's encephalopathy, or overdose. During treatment and recovery. 5. Ineffective coping related to inadequate coping mechanisms and poor stress management skills. Rationale: substance use is often a maladaptive coping strategy. Patients need to learn healthier alternatives. 6. Chronic low self-esteem related to stigma, shame, guilt, and repeated relapses. Rationale: many patients have internalized negative beliefs about themselves. 7. Social isolation related to damaged relationships, loss of support network, or social stigma. Rationale: isolation is both a risk factor for and a consequence of substance use disorder. 8. Deficient knowledge related to lack of information about the disease process, treatment options, and recovery resources. Rationale: education empowers patients to make informed decisions and engage in treatment. 9. Readiness for enhanced self-management related to the patient's desire to improve health and recovery outcomes. Rationale: recognizes patient strengths and motivation for change. Your role: select diagnoses that match the patient's current needs and treatment phase. Effective care planning requires SMART goals: specific, measurable, achievable, relevant, and time-bound. Let me show you examples. Diagnosis: risk for injury related to alcohol withdrawal. Wrong vague goal: patient will be safe. Correct. SMART goal: patient will remain free from falls, seizures, and self-harm during hospitalization, as evidenced by no injury incidents documented. Interventions: monitor CIWA-R score every 2 hours. Administer benzodiazepines as ordered based on CIWR score. Keep bed in low position with side rails up. Implement seizure precautions. Provide frequent reorientation if confused. Diagnosis: ineffective coping related to lack of healthy stress management strategies. Wrong vague goal: patient will cope better. Correct SMART goal: within 1 week, patient will identify and demonstrate 3 alternative coping strategies for managing stress without substance use. Interventions: teach deep breathing exercises and practice with patient. Introduce progressive muscle relaxation. Role-play refusal skills. Provide written list of coping strategies. Encourage journaling. Diagnosis: deficient knowledge related to medications for opioid use disorder. Wrong vague goal: patient will understand medications. Correct. SMART goal: before discharge, patient will verbalize correct dose, administration technique, and 2 side effects of buprenorphine, and will demonstrate sublingual administration technique. Interventions: provide written and verbal education about buprenorphine. Demonstrate sublingual administration. Have patient perform return demonstration. Review common side effects: headache, nausea, constipation. Provide medication information sheet. Schedule follow-up appointment with prescriber. Key principle: goals should be patient-centered, meaning they describe what the patient will do or achieve, not what the nurse will do. Therapeutic communication is one of your most powerful nursing tools. It builds trust, reduces defensiveness, and promotes healing. Let me share the core principles. 1. Use a non-judgmental approach. Patients with substance use disorders face enormous stigma and shame. They are often expecting judgment from healthcare providers. Your role is to provide unconditional positive regard, seeing the patient as a person of worth, separate from their behavior. Example: wrong. You did this to yourself. Why should we help you? Right. I'm here to support you. Substance use disorder is a medical condition and you deserve care. 2. Maintain confidentiality. Substance use disorder treatment records are protected by federal law, 42 CFR Part 2. Never share information without written patient consent, except in life-threatening emergencies. 3. Be honest and consistent. Don't make promises you can't keep. If you say you'll do something, follow through. Consistency builds trust, especially with patients who have experienced broken trust repeatedly. 4. Set clear boundaries. Be warm and empathetic, but professional. Avoid becoming overly involved or taking on a rescuer role. Setting boundaries protects both you and the patient. 5. Use empathy, not sympathy. Empathy is understanding and sharing the patient's feelings. I can see how difficult this is for you. Sympathy is feeling sorry for the patient. Oh, you poor thing. This can be patronizing. 6. Avoid confrontation. Confrontational approaches do not work. They increase defensiveness and resistance. Instead, use motivational interviewing techniques. We discussed these in Module 4. Let me teach you specific therapeutic communication techniques that are highly effective with substance use disorder patients. 1. Open-ended questions. These invite the patient to share more than a yes or no answer. Wrong. Do you want to stop using drugs? Right. What are your thoughts about your substance use? 2. Reflective listening. Paraphrase what the patient said to show you're listening and to clarify meaning. Patient. I know drinking is bad for me, but I don't know if I can quit. You. It sounds like you recognize the harm, but you're not sure you're ready to stop. 3. Normalizing. Help the patient understand that their feelings or experiences are common. Many people feel anxious when they first start treatment. That's a normal reaction. 4. Affirmations. Acknowledge the patient's strengths and efforts, even small ones. It took a lot of courage to come here today. You've been sober for 3 days. That's a real accomplishment. 5. Summarizing. Pull together what the patient has shared, highlighting key themes. So, if I'm understanding correctly, you're worried about your liver, you want to be there for your kids, but you're afraid of withdrawal. Is that right? 6. Silence. Don't be afraid of pauses. Silence gives the patient space to think and feel. After asking a difficult question, wait. Let them process. 7. Asking permission. This respects autonomy and reduces resistance. Would it be okay if I share some information about treatment options? These techniques create a safe, supportive environment where healing can begin. Now let me tell you about communication pitfalls to avoid. These are phrases that shut down conversation, increase shame, or damage the therapeutic relationship. 1. Avoid why questions. Why can sound accusatory and judgmental. Wrong. Why did you start using drugs? Why can't you just stop? Better. What led to your substance use? Or what makes it difficult to stop? 2. Don't minimize or dismiss. Wrong. It could be worse. At least you're not as bad as some people. Just snap out of it. These invalidate the patient's experience. 3. Avoid false reassurance. Wrong. Everything will be fine. I'm sure it will work out. You cannot guarantee outcomes. Be honest. Better. Recovery is possible and we're here to support you through it. 4. Don't give unsolicited advice. Wrong. You should just go to rehab. If I were you, This takes away the patient's autonomy. Better. What do you think would be most helpful for you right now? 5. Avoid moralizing or lecturing. Wrong. You're ruining your life. Think about what you're doing to your family. This increases shame and defensiveness. 6. Don't use stigmatizing language. Wrong. Addict, junkie, drunk, dirty urine, clean urine, substance abuse. Better. Person with substance use disorder. Patient. Positive or negative drug screen. Substance use. Language matters. Person-first language recognizes the person before the condition. Now let's discuss acute care interventions for patients presenting with intoxication. Initial assessment. ABCs first. Airway, breathing, circulation. Is the airway patent? Is the patient breathing adequately? Is there a pulse? What is the blood pressure? Level of consciousness. Use the Glasgow Coma Scale or AVPU scale. Alert, verbal, pain, unresponsive. Vital signs. Check for tachycardia, bradycardia, hypertension, respiratory depression, fever. Pupils, size, reactivity, symmetry. Remember, opioids cause pinpoint pupils. Stimulants cause dilated pupils. Skin, color, temperature, moisture. Look for injection marks, abscesses, or trauma. Immediate interventions. 1. Ensure safety. Place the patient in a safe environment. Use bed alarms if fall risk. Apply restraints only if necessary to prevent harm, following facility policy. 2. Position for airway protection. If decreased level of consciousness, place in recovery position, lateral recumbent, to prevent aspiration. 3. Administer oxygen if needed. If oxygen saturation is below 90% or patient shows signs of respiratory distress. 4. Obtain IV access. You may need to administer medications or fluids quickly. 5. Monitor continuously, vital signs every 15 minutes initially, then as condition stabilizes. 6. Administer reversal agents if indicated. For opioid overdose, naloxone, Narcan, 0.4 to 2 milliliter IV, IM, or intranasal. Repeat every 2 to 3 minutes if no response. For benzodiazepine overdose, flumazenil, used with extreme caution, can cause seizures in chronic users. 7. Obtain laboratory tests and toxicology screen, as ordered by provider. 8. Provide supportive care, IV fluids, electrolyte replacement, thiamine, if alcohol involved. Documentation. Record exact mental status, vital signs, objective behaviors, substances reported by patient or witnesses, interventions, and patient response. Withdrawal management requires vigilant monitoring and timely intervention. Alcohol. Withdrawal. Assessment. Use Kewar-R scale every 1 to 2 hours for the first 24 to 48 hours. Watch for signs of delirium tremens, hallucinations, severe confusion, agitation, fever, tachycardia, hypertension. This is a medical emergency. Interventions. 1. Administer benzodiazepines as ordered based on CIWS score. Example, lorazepam 1 to 2 mg IV or PO for CIWS score 10. 2. Give thiamine 100 mg IV or IM before any glucose administration to prevent Wernicke-Korsakoff syndrome. 3. Administer multivitamin and folic acid as ordered. 4. Replace electrolytes, magnesium, potassium, phosphate. 5. Provide IV hydration if patient is not taking adequate oral fluids. 6. Maintain a calm, quiet environment. Reduce stimulation. Dim lights if hallucinations present. 7. Reorient frequently if confused. 8. Monitor for seizures. Have suction and airway equipment at bedside. Opioid withdrawal. Assessment. Use Cow's scale every 4 to 6 hours. Interventions. 1. Administer comfort medications as ordered. Clonidine for autonomic symptoms. Loperamide for diarrhea. Ondansetron for nausea. Ibuprofen or acetaminophen for muscle aches. Hydroxyzine for anxiety. 2. If buprenorphine induction is planned, wait until Cow's score is 8 or higher before administering first dose. 3. Provide supportive care. Encourage fluids to prevent dehydration. Offer warm blankets for chills. Provide a quiet, supportive environment. 4. Reassure the patient. Remind them that opioid withdrawal is not life-threatening and symptoms will improve in 3 to 5 days. 5. Monitor for depression and suicidal ideation, which can occur during withdrawal. Your role: accurate assessment, timely medication administration, and compassionate support make withdrawal safer and more tolerable. Patients experiencing intoxication, withdrawal, or psychiatric crises may become aggressive or agitated. Your safety and the patient's safety are the top priorities. Early recognition. Watch for warning signs. Escalating verbal aggression. Raised voice, profanity, threats. Pacing, clenched fists, tense body language. Invading personal space. Paranoia or hallucinations. De-escalation techniques. 1. Stay calm. Your calm demeanor can help de-escalate the situation. Take deep breaths. Speak slowly and clearly. 2. Maintain a safe distance. Give the patient personal space, at least 2 arms lengths. Don't stand directly in front of them. 3. Use a non-threatening posture. Keep your hands visible and relaxed. Don't cross your arms. Stand at an angle, not face to face. 4. Use a calm, low voice. Avoid shouting or matching their tone. 5. Listen actively. I can see you're upset. Can you tell me what's wrong? 6. Validate their feelings without agreeing with distorted thoughts. I can see this is frustrating for you. 7. Set clear limits. I want to help you, but I need you to lower your voice and sit down. 8. Offer choices. Would you like to talk in a quieter room, or would you like some time alone first? When de-escalation fails. 1. Call for help. Use your facility's code system. 2. Ensure your exit route is clear. Never position yourself between the patient and the door. 3. Remove other patients from the area if possible. 4. Consider pharmacological intervention if ordered, oral or IM medication. 5. Physical restraints should be a last resort, used only when the patient is in imminent danger to self or others. Follow facility policy and legal requirements. After the incident, debrief with your team. Process your own emotional response. Document thoroughly. Remember, aggression is often a symptom of fear, pain, or impaired brain function, not personal animosity toward you. Pain management in patients with substance use disorder is complex and requires a balanced approach. The dilemma. Patients with substance use disorder experience pain just like anyone else, from injury, surgery, or chronic conditions. They have a right to adequate pain relief. However, there is often provider bias, fear of drug seeking, concerns about relapse, or reluctance to prescribe opioids. This leads to undertreated pain, which causes suffering and can actually trigger relapse. Guiding principles. 1. Believe the patient's report of pain. Pain is subjective. Use validated pain scales. Do not assume the patient is faking or exaggerating. 2. Address pain promptly. Uncontrolled pain activates the stress response and can worsen withdrawal symptoms. 3. Use multimodal analgesia. Combine non-opioid medications to reduce opioid requirements. Acetaminophen, scheduled, not PRN. NSAIDs, ibuprofen, ketorolac, if not contraindicated. Gabapentin for neuropathic pain. Lidocaine patches for localized pain. Ice, heat, positioning, relaxation techniques. 4. If opioids are needed, use them appropriately. Patients on methadone or buprenorphine for opioid use disorder often have opioid tolerance. They may require higher doses for acute pain. Their maintenance dose does not treat acute pain. It only prevents withdrawal. Additional pain medication is needed. 5. Avoid PRN dosing for chronic pain. Use scheduled dosing to maintain consistent pain control. 6. Coordinate with the addiction team. Involve addiction specialists in pain management decisions. 7. Provide clear communication. Explain the pain management plan to the patient. Set realistic expectations. 8. Monitor for signs of misuse, but do so objectively, not punitively. 9. Plan for discharge. If the patient needs opioids at discharge, prescribe a limited supply and arrange close follow-up. Connect to outpatient pain management and addiction services. Your role: advocate for appropriate pain management while supporting recovery. Opioid overdose is a medical emergency. Your rapid response saves lives. Recognizing opioid overdose. Classic triad. 1. Unresponsiveness or decreased level of consciousness. 2. Respiratory depression, slow, shallow breathing or apnea. 3. Pinpoint pupils. Other signs: cyanosis, bradycardia, hypertension, cold and clammy skin. Immediate actions. 1. Ensure safety and call for help. 2. Assess responsiveness. Shout the patient's name, tap shoulders, perform sternal rub. 3. Call for emergency assistance. 4. Open the airway, head tilt, chin lift maneuver, check for obstructions. 5. Assess breathing. Look, listen, feel for 10 seconds. 6. If not breathing or inadequate breathing, begin rescue breathing or bag valve mask ventilation. Provide oxygen if available. 7. Administer naloxone immediately. Naloxone administration. Intranasal route. Assemble nasal spray device. Place patient supine. Insert tip into one nostril and press plunger firmly. If no response in 2 to 3 minutes, give second dose in other nostril. Intramuscular route. Draw up 0.4 to 2 mg. Inject into deltoid, thigh, or gluteal muscle. Repeat every 2 to 3 minutes if no response. You can give multiple doses. Intravenous route, if IV access available. Administer 0.4 to 2 mg slow IV push. Titrate to restore breathing, not full consciousness. After naloxone. Administration: 1. Position the patient in recovery position to prevent aspiration. 2. Monitor closely. Naloxone has a short half-life. The patient can resedate if the opioid in their system is long-acting. 3. Expect withdrawal symptoms. Naloxone will precipitate withdrawal. The patient may be agitated, anxious, nauseous, or combative. 4. Transport to emergency care. Many patients try to leave after naloxone. Educate them about the risk of resedation. 5. Provide naloxone education and take-home kit if available. Important. Naloxone is safe. It has no effect if opioids are not present. When in doubt, give it. There is no downside. Discharge planning should begin on admission. Transitions are high-risk times for relapse. Essential components. 1. Continuing care appointment. Schedule the first outpatient appointment before discharge, ideally within 7 days. This might be with an addiction counselor, provider, primary care, or psychiatrist. Do not discharge without a clear plan for follow-up. Follow-up as needed is not a plan. 2. Medication reconciliation. Review all medications for substance use disorder, co-occurring conditions, and withdrawal management. Provide written medication list with doses, times, and purposes, prescriptions with sufficient supply until follow-up, patient education about each medication. 3. Community resource referrals. Connect the patient to 12-step meetings or alternatives, peer support services, housing assistance if unstably housed, social services, food assistance, transportation, childcare, vocational rehabilitation. Provide written information with contact numbers. 4. Crisis plan. Ensure the patient knows what to do in an emergency. Crisis hotline numbers like 988 or SAMHSA National Helpline. Emergency department contact information. When to seek help. Suicidal ideation, severe withdrawal symptoms, overdose risk. 5. Relapse prevention plan. This should include warning signs of relapse, emotional, mental, physical, personal triggers and high-risk situations, coping strategies for each trigger, support contacts, sponsor, therapist, family member, emergency plan if relapse occurs. Provide this in written format. 6. Family education. If the patient consents, educate family about what to expect in early recovery, how to support without enabling, warning signs of relapse, community resources for families. 7. Naloxone kit. Provide a take-home naloxone kit and train the patient and family on its use. Education empowers patients and families to actively participate in recovery. Teach back method. After teaching, ask the patient to explain back to you in their own words. Can you tell me what you'll do if you start feeling like you want to use? This confirms understanding and identifies gaps. Key education topics. 1. Substance use disorder as a chronic disease. Explain. It is a brain disease, not a moral failing. It is chronic, like diabetes. It requires ongoing management. Relapse is common and does not mean failure. 2. Medications for treatment. For each prescribed medication, teach, name and purpose, dose and schedule, how to take it, expected benefits, side effects to expect, what to do if side effects occur, why not to stop abruptly. 3. Trigger identification and coping skills. Help the patient identify personal triggers, people, places, things, emotions. Teach alternative coping skills. Halt check. Am I hungry, angry, lonely, or tired? Deep breathing and relaxation techniques. Call someone, sponsor, therapist, friend. Go to a meeting. Engage in physical activity. Use distraction. 4. Relapse warning signs. Teach the 3 stages of relapse: emotional, mental, physical. Intervene early. Don't wait until physical relapse. 5. Overdose prevention and naloxone use. Teach risk factors for overdose, signs of overdose, how to administer naloxone. Call 911 immediately after giving naloxone. 6. Importance of ongoing treatment. Emphasize: attend all appointments, go to support group meetings regularly, take medications as prescribed, build a sober support network. Recovery is a marathon, not a sprint. Stigma is one of the greatest barriers to effective substance use disorder care. What is stigma? Stigma is negative attitudes, beliefs, and behaviors directed toward people with substance use disorder. It includes stereotyping, all addicts are criminals. Prejudice, they did this to themselves. Discrimination, they don't deserve treatment. Stigma in healthcare. Research shows that healthcare providers, yes, including nurses, often hold stigmatizing attitudes toward patients with substance use disorders. Examples: believing patients are drug-seeking when reporting pain, providing lower quality care, or treating patients dismissively, using stigmatizing language, addict, junkie, dirty urine, blaming patients for their condition, why should we treat them when they did this to themselves? This stigma causes real harm. Patients delay seeking care because they fear judgment. They disengage from treatment when they feel disrespected. Health outcomes worsen when care is substandard. Your role in reducing stigma: 1. Examine your own beliefs. We all have unconscious biases. Reflect honestly. Do I treat patients with substance use disorder differently than patients with diabetes or heart disease? Do I assume they are lying or manipulating? Do I feel frustrated or resentful when caring for them? Awareness is the first step toward change. 2. Use person-first language. Language shapes attitudes. Wrong, the addict in room 10. Right, the patient with opioid use disorder in room 10. Wrong, substance abuser. Right, person with substance use disorder. Wrong, dirty urine. Right, positive drug screen. 3. Educate colleagues. If you hear stigmatizing language or witness discriminatory behavior, speak up. I prefer to say person with substance use disorder rather than addict. Share evidence about the neurobiology of addiction. 4. Treat patients with dignity and respect. Every patient deserves compassionate care, regardless of the reason for their illness. 5. Advocate for equitable treatment. Ensure patients with substance use disorder receive the same standard of care as all patients. Challenge policies that are discriminatory. For example, blanket bans on opioid pain medications for patients in recovery. Stigma ends with you. Be the change. Caring for patients with substance use disorder can be emotionally demanding. You witness suffering, relapse, and sometimes death. This takes a toll. Self-care is not optional. It is essential for sustaining your career and your well-being. Burnout versus compassion. Fatigue. Burnout, a state of emotional, physical, and mental exhaustion caused by prolonged stress. Symptoms: feeling emotionally drained and depleted, detachment or cynicism toward work, reduced sense of accomplishment. Physical symptoms: fatigue, headaches, insomnia. Compassion. Fatigue, also called secondary traumatic stress. It occurs when you absorb the trauma of those you care for. Symptoms: intrusive thoughts about patients suffering, emotional numbness or avoidance, hypervigilance or anxiety, difficulty separating work from personal life. Warning signs to watch for: you dread going to work. You feel irritable or resentful toward patients. You find yourself thinking, they're never going to change, why bother? You're making mistakes or forgetting things. You're withdrawing from colleagues or loved ones. You're using substances to cope. If you recognize these signs, take action. Here are evidence-based strategies to protect your well-being and build resilience. 1. Set boundaries between work and home. Don't take work home, physically or mentally. Develop a transition ritual, change clothes, take a walk, listen to music on your commute. This signals to your brain that work is over. 2. Practice mindfulness and stress reduction. Deep breathing exercises, meditation or mindfulness apps, yoga or Tai Chi, progressive muscle relaxation. Even 5 minutes a day can reduce stress. 3. Engage in physical activity. Exercise is one of the most effective stress relievers. Find something you enjoy: walking, dancing, swimming, cycling. Aim for 30 minutes most days. 4. Maintain social connections. Isolation worsens burnout. Spend time with supportive friends and family. Join a nurse support group or peer supervision group where you can process difficult cases. 5. Seek professional support. If you're struggling, see a therapist. Many healthcare systems offer employee assistance programs, EAP, with free confidential counseling. Therapy is not a sign of weakness. It is a sign of self-awareness and strength. 6. Practice self-compassion. Be kind to yourself. You will not save every patient. Some will relapse, some will die. This does not mean you failed. You did your best with the tools and knowledge you had. That is enough. 7. Find meaning and purpose. Reconnect with why you became a nurse. Celebrate small victories. A patient who completes detox, a patient who attends their first 12-step meeting, a patient who says, "Thank you for not giving up on me." These moments matter. 8. Take breaks and use your time off. Don't skip lunch breaks. Use your vacation days. Rest is not selfish, it is necessary. 9. Advocate for workplace support. Speak up about staffing ratios, workplace safety, access to debriefing after critical incidents. Organizations have a responsibility to support nurse well-being. 10. Know when to seek a change. If your workplace is toxic, your health is suffering, and efforts to improve the situation have failed, it may be time to consider a different role or setting. Your health comes first. Substance use disorder care requires a team approach. No single provider can address all the complex needs of these patients. Key team members. 1. Physicians and nurse practitioners. Diagnose, prescribe medications, manage medical complications. 2. Addiction counselors and therapists. Provide individual and group therapy, develop treatment plans. 3. Social workers. Coordinate resources, arrange housing, connect to social services, discharge planning. 4. Pharmacists. Educate about medications, monitor for interactions, support adherence. 5. Peer support. Specialists. Individuals in recovery who provide support, mentorship, and hope. 6. Case managers. Coordinate care across settings, ensure follow-up, track outcomes. 7. Psychiatrists and psychiatric nurses. Treat co-occurring mental health disorders. 8. Pain management. Specialists address chronic pain in patients with substance use disorder. Nurses as coordinators. You are often the hub of the interdisciplinary team. You see the patient most frequently. You observe changes. You communicate needs to other team members. Effective collaboration. Attend team meetings and contribute to your observations. Communicate clearly and respectfully with all team members. Respect each discipline's expertise. Advocate for the patient when their needs are not being met. Avoid silos. Share information within confidentiality limits. A strong team produces better outcomes. Substance use disorder care raises important ethical and legal issues. 1. Confidentiality, 42 CFR Part 2. Federal law protects substance use disorder treatment records. You cannot disclose that a patient is receiving substance use disorder treatment without written consent, except in specific circumstances. Medical emergency, child abuse reporting, or court order. Be cautious. Even confirming a patient is in your program can be a violation. 2. Informed consent. Patients have the right to understand their diagnosis and treatment options, make informed decisions, and refuse treatment. Ensure the patient understands risks and benefits of medications and treatment level. 3. Autonomy versus beneficence. Sometimes the patient's choice conflicts with what you believe is best for them. Respect their autonomy while providing education and support. You cannot force treatment except in imminent danger. 4. Mandatory reporting. Be aware of your state's mandatory reporting laws regarding child abuse, elder abuse, or threats of harm. 5. Pain management and opioid prescribing. Follow facility policies and state laws regarding prescribing limits and PDMP. Avoid punitive approaches. Pain is real. 6. Workplace rights for healthcare. Workers in recovery. Healthcare workers have rights under the ADA. Most states have alternative to discipline programs. Support colleagues in recovery. Stigma exists within our profession too. Let's consolidate what we've learned in Module 5. Remember, the nursing process is your framework. Assess, diagnose, plan, implement, evaluate. Priority nursing diagnoses include risk for injury, ineffective coping, chronic low self-esteem, social isolation, and deficient knowledge. SMART goals are specific, measurable, achievable, relevant, and time-bound. Therapeutic communication builds trust. Use open-ended questions, reflective listening, affirmations, and avoid judgmental language. Acute care interventions for intoxication and withdrawal save lives. Know your protocols, use assessment scales, administer medications appropriately. Naloxone administration is a critical skill. When in doubt, give it. It is safe and life-saving. Discharge planning begins on admission. Ensure follow-up appointments, medication reconciliation, community resources, crisis plan, and relapse prevention plan. Patient education empowers recovery. Teach about the disease, medications, triggers, coping skills, and warning signs. Address stigma. Use person-first language, treat patients with dignity, educate colleagues, and advocate for equitable care. Self-care is essential. Recognize signs of burnout and compassion fatigue. Use evidence-based strategies to protect your well-being. Interdisciplinary collaboration produces the best outcomes. Respect each team member's role and communicate effectively. Know your ethical and legal responsibilities, especially regarding confidentiality, informed consent, and mandatory reporting. You have now completed all 5 modules of nursing management of substance use disorders. You have gained knowledge and skills in the foundations and epidemiology of substance use disorder, recognizing clinical presentations across substance classes, conducting systematic assessments using validated tools, understanding treatment modalities and pharmacotherapy, implementing nursing interventions, and supporting rehabilitation. But knowledge is only the beginning. Your true impact comes from how you apply this knowledge with compassion, skill, and courage. You are on the front lines of the opioid epidemic, the alcohol crisis, and the stimulant surge. You will encounter patients in the emergency department, on medical surgical units, in ICUs, in community health centers, and in psychiatric facilities. You have the power to recognize substance use disorder early, provide life-saving interventions, offer hope when patients feel hopeless, advocate for evidence-based treatment, reduce stigma through your words and actions, support patients through the difficult journey of recovery. Not every patient will recover. This is the painful reality of chronic disease. But every patient deserves compassionate, evidence-based care, and many will recover because of the care you provide. You are not just a nurse. You are a healer, an advocate, an educator, and a champion for those society often overlooks. Thank you for your dedication to this essential work. Thank you for completing this course. And thank you for the care you provide to patients with substance use disorders every single day. Your work matters. You matter. Go forward with confidence, compassion, and courage.